I'd like to thank the organizers for inviting me to present. Today, I'll be focusing my discussion on common adrenal and thyroid disorders that you're likely to encounter in the care of hospitalized patients. My name is Carl Pallais. I'm one of the senior physicians in the Division of Endocrinology at Brigham and Women's Hospital. And I'd like to add that prior to coming to the Brigham, I was one of the founding members of the MGH Clinician Educator Service, where part of my time was working as a hospitalist, supervising residents in the teaching service. So I have a good sense of the type of endocrine disorders that you may encounter. These are my disclosures, and they're not relevant at all to this presentation. And this is the outline of my talk. And as you can see, I have a lot to cover, so let's just go ahead and get started. So I'll start off by first discussing adrenal insufficiency, which comes up all the time in differential diagnosis of patients with weakness, fatigue, and other nonspecific symptoms like myalgias, arthralgias, orthostasis, fever, nausea, vomiting, and abdominal pain, which many of our hospitalized patients tend to have. And I'd like to point out, however, that adrenal insufficiency is frequently associated with anorexia and weight loss and can sometimes be ruled out if somebody is gaining weight due to increased appetite. Also, hyponatremia is common in adrenal insufficiency, and it is caused by the decreased cortisol feedback, which then stimulates ADH production from the hypothalamus as ADH is co-secreted with CRH, or corticotropin releasing hormone, in the periventricular nucleus. Some signs and symptoms of adrenal insufficiency are only present depending on the underlying etiology, with primary adrenal insufficiency being associated with hyperpigmentation due to high ACTH levels, hyperkalemia due to decreased aldosterone, and also other associated autoimmune disorders can also be present in the setting of autoimmune Addison's disease, which is the most common cause of primary adrenal insufficiency. So central adrenal insufficiency, which is most often caused by glucocorticoid withdrawals, but also increasingly due to immune checkpoint inhibitors that can sometimes be associated with pituitary dysfunction or mass effects when caused by hypothalamic or pituitary disorders. Patients with adrenal insufficiency, either primary or central, are at risk for adrenal crisis, which is characterized by hypotension or shock from decreased vascular tone, plus or minus a decreased vascular volume. The patients can also have delirium, psychosis, acute abdomen with fever and frequent hyponatremia, as we discussed, and occasional hypoglycemia. Adrenal crisis can be triggered by any acute event such as infection, trauma, acute illness, or hyperthyroidism, which tends to increase the metabolism of cortisol, and that can unmask the adrenal insufficiency. So this condition requires immediate treatment. So adrenal crisis does require, it's an emergency, it's a true medical emergency that requires immediate treatment with aggressive hydration, electrolyte repletions, and also stress dose steroids. So testing for adrenal insufficiency can be done by measuring morning cortisol levels with levels greater than 14 micrograms per deciliter, ruling out adrenal insufficiency, whereas levels less than 3 being suggestive of adrenal insufficiency. However, random cortisol measurements are often indeterminate. It is useful. They can be useful in suspected adrenal crisis prior to the treatment of normal levels as prior to the treatment, because normal cortisol levels may allow you to stop exogenous steroids if the levels actually are subsequently found to actually end up being elevated. So another test for adrenal function involves the concentropin stimulation test. And here you measure cortisol levels about 1 hour after the administration of 250 micrograms of concentropin or synthetic ACTH. This test for the presence of adrenal, this is a test for the presence of adrenal atrophy, and it can be ruled out if the post-stimulation cortisol levels are greater than 14 micrograms per deciliter on the newer assays, although this cutoff is higher in the older assays, which also tend to measure the inactive cortisol metabolites. So usually we used to use 18 in the older assays. The cortisol levels can be falsely normal in acute central adrenal insufficiency when the adrenal has not yet had a chance to atrophy. It can also be falsely normal in the setting of elevated corticosteroid binding globulin, or CBG, as can occur in patients who are taking oral contraceptives. And cortisol levels can be falsely low in the setting of low CBG. An important point to keep in mind, which is what I was alluding to before, in interpreting the cortisol values, is that more than 90% of the circulating cortisol levels are protein bound, primarily to CBG, or corticosteroid binding globulin, but also to albumin. And only the free cortisol is biologically active. So conditions that change the CBG or albumin can change the total cortisol measurements without necessarily changing the free component. So estrogens can increase the CBG by 2 to 3-fold and can result in falsely normal cosentropin stimulations tests despite the presence of adrenal insufficiency. Cirrhosis, nephrotic syndrome, or critical illness can falsely lower the cortisol levels by lowering the CBG, and also these conditions tend to also lower the albumin levels. And this is why it's recommended to qualitatively adjust the cortisol values if the albumin level is less than 2.5 grams per deciliter. You do need to rely a bit more on clinical judgment and interpretation of the cortisol levels in conditions that do lower the albumin levels, and something that happens a lot when taking care of patients with cirrhosis. So to distinguish primary versus central causes of adrenal insufficiency, it is important to measure ACTH, or adrenocorticotropin hormone, in the setting of low cortisol values. So ACTH is elevated in primary adrenal insufficiency, which is frequently associated with low DHEAS levels, as well as hyperkalemia with increased renin due to the low aldosterone due to aldosterone deficiency. So in contrast, central adrenal insufficiency is associated with low or inappropriately low ACTH levels, normal potassium, because the aldosterone is controlled independently for ACTH, so it should be working, so it still regulates potassium levels. And also, a normal DHEAS level can be helpful in ruling out a primary etiology, although it is not helpful if the DHEAS levels are low, because it could still point to either primary or central because of a prolonged adrenal atrophy. As we discussed, some hypothalamic pituitary causes can also give rise to other pituitary abnormalities. So if you think of a central etiology, make sure that you at least think about the possibility of having other pituitary dysfunction. But the two most common causes of central adrenal insufficiency are now checkpoint inhibitors causing autoimmune hypophysitis and chronic glucocorticoid withdrawals, and these tend to have isolated ACTH deficiencies. One of the most common causes of central adrenal insufficiencies are exogenous steroids, leading to suppression of the hypothalamic pituitary adrenal axis. And these diagrams show diurnal ACTH secretions from the pituitary on 4 subsequent days. The administration of high doses or highly potent steroids, or those with very long duration of action, can tend to inhibit ACTH secretion more than those that have than low doses or short-acting agents, and thus have a greater risk of inducing adrenal insufficiency, the greater the risk of suppression of this ACTH surge. Because of the diurnal pattern of secretion of ACTH, even low doses of steroids can have a dramatic reduction in the morning ACTH surge if they're given in the afternoon, and this may lead to adrenal atrophy if it's done in a prolonged basis. Because it takes approximately 2 to 3 weeks of ACTH suppression to atrophy the adrenal glands, long-term duration of treatment is a key factor in inducing adrenal insufficiency. So for your reference, I've arranged some of the common glucocorticoids according to increasing glucocorticoid potency, from corticosterone to dexamethasone, with hydrocortisone, which is another name for exogenous cortisol, being used as the standard. I've also listed the relative mineralocorticoid receptor activity here in the third column. And as you can see, prednisone and prednisolone are about 4 to 5 times more potent than hydrocortisone, whereas dexamethasone is approximately 25 times more potent. And I color-coded the drugs according to the biologic duration of action, with those agents in green lasting about 10 hours, those in yellow lasting about 20 hours, and in red about 40 hours. And this is why prednisone can be dosed once a day, whereas hydrocortisone needs to be dosed at least twice a day. You can use any of these agents to treat adrenal insufficiency, with the typical replacement doses being hydrocortisone 15 milligrams in the morning and 5 milligrams in the afternoon. It can be slightly, we tend to actually end up using higher doses in hospitalized patients. And this is equivalent to approximately 5 to 7.5 milligrams of prednisone per day. Mineralocorticoid replacement with fludrocortisone is required for patients with primary adrenal insufficiency. And it is important to review sick rules with patients and providers with a recommending doubling or tripling of the maintenance glucocorticoid dose for about 2 to 3 days in the setting of fever or other illnesses. And there's usually no need to increase the fludrocortisone dose as long as the potassium levels remain normal. So a question that comes up all the time in hospitalized patients is the need to give patients stress doses. The answer is yes for someone on physiologic replacement undergoing procedures, with increase in the dose dependent on the invasiveness of the procedure, ranging from about 25 milligrams IV of hydrocortisone at the time of colonoscopy to 50 milligrams of hydrocortisone with orthopedic surgery, followed by 25 milligrams every 8 to 12 hours, depending on the vital signs. And you can actually end up giving up for certain procedures like major surgery, like a CABG. Then we tend to actually end up giving the full stress doses of 100 milligrams of hydrocortisone, followed by 50 milligrams every 6 to 12 hours for these very large surgeries. Stress doses are not usually required in patients on supraphysiologic doses, like 2 milligrams of dexamethasone every 6 hours or 50 milligrams of prednisone, as these doses are already close to the stress doses. But we do need to increase the glucocorticoid dose on somebody who's only on maintenance doses, or have a low threshold to start stress doses on someone who just recently stopped a 2-week course of 8 milligrams of dexamethasone about 5 days ago. And that's because the higher doses and longer half-life of dexamethasone, it is very likely to have caused some adrenal atrophy, as the drug may still be wearing off by then and putting the patient at risk for adrenal insufficiency. And here are listed some of the common equivalent doses of the different glucocorticoids, with 20 milligrams of hydrocortisone being briefly equivalent to 5 milligrams of prednisone or 4 milligrams of methylprednisolone and 0.75 milligrams of dexamethasone. So I'd like to also point out the relative mineralocorticoid activity of the different agents, which is important in determining the effect that they're going to end up having on the potassium levels. And that's as demonstrated by this patient with alcoholic cirrhosis and ITP, idiopathic thrombocytopenia, who was started on 400 milligrams of IV hydrocortisone per day, but this resulted in acute hypokalemia that led to torsades. That's the lower mineralocorticoid activity is the reason we tend to use IV methylprednisolone or dexamethasone whenever we have to give high doses of steroids. And we tend to stay away from hydrocortisone or even prednisone for steroid pulses. So I'd like to start my discussion of adrenal nodules with a clinical vignette and a question. So the vignette is that of a 62-year-old woman with a 40-pack year smoking history, remote history of lung cancer, status post wedge resection, without history of recurrence, and hypertension on lisinopril and amlodipine, who's admitted with pyelonephritis and is found to have 2 hypodense adrenal nodules with smooth borders measuring 2.5 centimeters on the right and 1.5 centimeters on the left on abdominal CT. Serum electrolytes were normal. So the question is, which of the following is the most important indicator of the malignant potential of the adrenal incidentuloma? A, size, B, high fat content of the nodules, C, hormonal status, D, smooth borders, or E, bilateral involvement. So I'll just give a little bit of time so you have an opportunity to choose your answers before I give you the right answer. So now for the right answer, based on prior responses, my guess is that a number of you actually chose E, that was like bilateral involvement, but the right answer is B. The high fat content of the nodules is the most important indicator of the malignant potential of an adrenal lesion. And we'll discuss that in more detail in just a second. So first, let me just discuss exactly what do we mean by adrenal incidentaloma. So it is an adrenal mass that's greater than 1 centimeter in diameter that was incidentally discovered during radiographic evaluation, done for reasons other than to look for adrenal pathology, just like in the vignette that I described before. And because of the widespread use of abdominal imaging, adrenal incidentalomas have been increasing in incidence over the last 2 to 3 decades. And is something that we're very much likely to end up seeing in hospitalized patients. So both autopsy and population studies have shown that the prevalence of adrenal nodules in the general population is approximately 5%, with the prevalence increasing with age. So that's less than 1% in the third decade, but rises to about 7% in older age. And the two major questions that one must address when faced with an adrenal incidentaloma are whether it is malignant or if it's functional. And we'll address both of these in the subsequent slides. So to start this discussion, it's important to briefly review some normal adrenal physiology. So the adrenal cortex is made up of 3 layers, the zona glomerulosa, fasciculata, and reticularis, or GFR as a mnemonic, which make aldosterone, cortisol, and DHEA respectively. And all of these steroid hormones are derived from cholesterol, which means that they need to be maintained in a lipid-rich environment. As can be seen in this picture, you can see that the cortical cells do indeed contain a high amount of lipid, which is shown in white. And that's in contrast to the medulla, which is quite vascular with very little lipid content. And that's the medulla is made up of neural crest cells, derived chromaffin cells that secrete epinephrine. And that's just a small little amino acids that does not need to be in a lipid-rich environment. So determining the fat content is a critical step in evaluating an adrenal mass. Benign myelolipomas or cortical adenomas have high fat content, which is characterized by an appearance of low attenuation, a very fast washout on a CAT scan, or a loss of signal on an out-of-phase imaging in a chemical shift MRI. And in contrast, low fat content is found in every other lesion, whether it's benign lipid poor adenoma, an infection, or pheochromocytoma, or malignancy. And that's usually can be either malignant adrenal cortical carcinoma or metastases. So other important predictors of malignant potential include the prior cancer history, as patients with a prior history of cancer, particularly these cancers like lung, breast, kidney, and GI cancers, have a high risk of metastatic lesions, and they can be bilateral, approximately 10 to 15% of the time. And it is important to note that most case series from which these numbers arise are biased towards malignancy, as all patients with cancer have a lot more imaging, and there's a surgical bias towards malignant apparent lesions. Whereas in patients with no known cancer history, most of the lesions are actually that are found incidentally tend to end up being benign. Tumor size is another important feature that determines malignant potential, with lesions less than 4 centimeters having a low likelihood of malignancy. However, this is for patients without a known history of a cancer. It's really important to remember because adrenal mets tend to be smaller than 4 centimeters. So this is actually going to be for patients who don't have any history of cancers. If the lesions tends to be less than 4 centimeters, then it's much more likely to end up being benign. But you cannot actually end up making that assumption if somebody has a prior history of a lung cancer, because it may actually end up being, even though the lesion is less than 4 centimeters, it may actually end up being a metastases. And most metastases tend to be small, around the 2 centimeter size. So it is important to evaluate the full radiographic phenotype of the lesion, with good features being associated with high fat content, smooth borders, homogeneous appearance, slow growth, and the absence of tracer uptake on PET scan. Whereas bad features include low fat content, irregular borders, heterogeneous appearance, and rapid growth on repeat imaging, as well as increased tracer avidity on PET scans. And this is a very nice summary diagram of what we just discussed when evaluating the malignant potential of an adrenal mass. First, you look at the fat content, as high fat content is associated with benign conditions. And for lesions with low fat content, then you look for radiographic phenotype, which includes tumor size to determine malignant potential. But it's also important to look at other radiographic and clinical features, as adrenal mets tend to be, like as I mentioned before, tend to be smaller than 4 centimeters. And both adenomas, PHOs, and mets can be bilateral. So this is not a particularly helpful feature to determine the malignant potential at all. So approximately 30% of adrenal incidentalomas are functional, but 25% have mild autonomous cortisol secretion, or MAX, that can give rise to subclinical Cushing's, but can cause full-blown Cushing syndrome in about 5% of cases. Pheochromocytomas account for about 7% of adrenal incidentalomas, and I should point out that nowadays it's a lot more common to identify a pheo as an incidental finding rather than through the classic presentation. And in fact, only about 50% of incidentally discovered pheos had hypertension. So it is an expanding spectrum of disease. Aldosterone secreting adenomas make up about 1–5% of adrenal incidentalomas, and most of these are associated with hypertension. The functional evaluation of adrenal incidentalomas include a careful history and physical and hormonal testing, and we'll discuss each of these separately. However, before proceeding with an extensive evaluation in the hospital, you have to have a really good reason for not wanting to do it as an outpatient, as the increased stress of hospitalization can result, or the illness of hospitalization can result in cortisol and catecholamine levels that are elevated, and that can give rise to false positive tests. And doing more definitive radiographic studies several months later, also, rather than just in the hospital, will also allow you to assess tumor growth. So that's going to be another important determination in terms of the malignant potential assessment. However, you should consider testing for hormone excess in the setting of hypertensive urgency or emergencies to look for secondary causes of hypertension, if this has not already been done. And with hyperaldosteronism being significantly much more common than Cushing's disease or pheochromocytomas as the cause of the hypertensive urgency. You should also consider evaluating for pheochromocytoma in patients with a lipid-poor incidentalloma who's awaiting a surgical procedure to avoid the risk of triggering a catecholamine crisis during the procedure. You can consider testing for cortisol excess in someone with frank Cushingnoid features, and adding an evaluation of primary hyperaldosteronism in someone with difficult controlled hypertension and hypokalemia. So at this point, it's worth reviewing some of the signs and symptoms for each of the hypersecretion conditions. And here are listed some of the signs and symptoms of Cushing's. Most are nonspecific, but among those with the greatest specificity include the EC bruising, proximal muscle weakness, violaceous wide striae that's different from the thin striae associated with just run-of-the-mill obesity. And because of the increased cortisol levels can bind to mineralocorticoid receptor, the presence of hypokalemia can also be a marker of cortisol excess. And here are listed some of the signs and symptoms of pheochromocytomas with a good mnemonic that I learned a while back with the 10 Ps. So the first 4 are among the most common, and that includes the pounding headaches, perspiration, palpitation, and pressure abnormalities, which can also include orthostasis. And that's because you actually tend to be volume deplete. Pallor is a feature, but flushing is very uncommon in pheochromocytoma. So it is actually something to remember that somebody comes in complaining of flushing, it actually rarely ends up being pheochromocytoma. But if they actually end up having pallor, it's a lot more likely that they have a pheochromocytoma as the underlying cause. Paroxysmal spells can sometimes occur. And fever, which is a little bit of a stretch, or I should probably have changed that to pyrexia, can be a common finding in pheochromocytomas. And GI side effects are common, with constipation or plugging being a feature. And anorexia is very common. It's frequently associated, as pheochromocytomas are frequently associated with weight loss. And here I listed as poor appetite, but some people remember it as puking. And occasionally we'll see patients with anxiety and tremor, which can be remembered as panic attacks. And lid lag is a common feature seen in patients with pheochromocytoma, and this can be categorized as a palpebral lag. And some of the associated lab findings include hemoconcentration, hypercalcemia, and hyperglycemia. The characteristics of hyperaldosteronism include hypertension, hypokalemia, and metabolic alkalosis. But it is really important to remember that more than 2/3 of patients with primary aldosteronism had normal potassium levels. You can't exclude primary aldosteronism based on the normal potassium levels. Symptoms tend to usually end up being caused by hypokalemia in patients with primary aldosteronism, if not hypertension. But those associated with hypokalemia include muscle cramps, paresthesias, and polydipsia. But it is really important to remember that primary aldosteronism is one of the most common secondary causes of hypertension, with increasing prevalence of primary aldosteronism found with worsening hypertension. And it makes up about 20% of patients. The primary aldosteronism accounts for about 20% of patients who have resistant hypertension. And these patients you are likely to end up seeing in the hospitalized setting. Primary aldosteronism is also enriched in hypertensive patients with hyperkalemia, those with obstructive sleep apnea, those who have young age and no family history, or those who have a positive family history of strokes and atrial fibrillation, particularly at young ages. So because of its relatively high prevalence, I do think that we should be doing a lot more screening for primary aldosteronism in hospitalized patients. And this involves the concurrent measurements of aldosterone levels and renin activity, with a positive screen resulting from aldosterone to renin ratio greater than 20 and an aldosterone level that's greater than 8 to 10 nanograms per deciliter. So moving on to hypercortisolism, there are 3 possible screening tests for Cushing's. These include 1, the overnight 1 milligram dexamethasone test, which is the recommended starting test for patients with adrenal incidentalomas. And here you give 1 milligram of dexamethasone between 11 p.m. and midnight, and you measure the cortisol levels between 8 and 9 a.m. the following morning, with the positive screening test indicated by a non-suppressed cortisol level greater than 1.8 nanograms per deciliter in Cushing's patients and greater than 5 nanograms per deciliter if the patient's not Cushing's. You basically end up having a slightly higher threshold to end up saying that's a positive test for somebody who doesn't have a lot of the Cushing symptoms. You can also, the second test is that you can also measure midnight salivary cortisols, which are typically suppressed at bedtime because of diurnal pattern of secretion of cortisol, although this has a very high false positive rates in patients with impaired diurnal rhythms. And the third test, which is the most quantitative test, is that of a 24-hour urine-free cortisol measurement. But it is important to note that this may also be falsely elevated in hospitalized patients due to the physiologic stress of the underlying illness. So you have to actually end up being careful about how you interpret some of these values in hospitalized patients. And now moving to a measurement of assessments for pheochromocytoma. The measurement of plasma interference is the easiest way to test for pheochromocytoma. And this test is quite sensitive, meaning that a negative test does usually indicate that the patient does not have a pheo, but these tests are not specific. And the specificity tends to decrease with age. And with the severity of the underlying illness that results in the hospitalization, can also end up increasing the levels of catecholamines, plasma norepinephrines, so that can actually end up leading to a falsely elevated level. So it is difficult to end up interpreting a positive test in hospitalized patients unless it is significantly higher than the upper limits of normal. So if any of these screening tests come back positive, then additional confirmatory tests are needed. And I listed these here, but won't have a lot of time to end up discussing this further in the interest of time. And these tests are generally a lot more specific. And if the confirmatory test is positive, then the next step usually ends up being surgery to actually end up removing the tumor, the adrenal tumor, so it stops starts actually causing clinical symptoms because of the hormone production. And the only exception you should know about is that bilateral aldosteronism is typically, which is the most common one in patients with hypertension and primary aldosteronism, tends to actually end up being managed medically with mineralocorticoid receptor antagonists like spironolactone or Pallais, rather than having a surgical cure. We tend to reserve those only if somebody has had confirmation of unilateral aldosterone production after adrenal venous sampling. So in the time that we have left, I'd like to cover some of the common thyroid disorders that you're likely to end up encountering in hospitalized patients. And I'd like to start off this section by reminding that any set of TFTs, a thyroid function test, provides a very static view of a dynamic process. And it works really well. They work very well in most conditions, but in others, it is important to remember that we may need repeat testings to determine exactly what's actually going on, just like we would need to have another picture to determine whether this train on the right is actually moving to the left or to the right of the screen. And another thing to remember is that although TSH is generally the most important measurement for both the diagnosis of thyroid dysfunction and in the chronic treatment of hyper or hyperthyroidism, in the first few weeks to months after initiation of treatment, the free T4 may be the most diagnostically accurate test, as the free T4 corrects before the TSH levels do. And this lag depends on both the severity as well as the duration of the thyroid dysfunction, and can range from a few weeks to several months in severe cases. So given this timescale of testing in hospitalized patients, you should have a low threshold to add a free T4 levels to the TSH measurements in hospitalized patients. These principles can be nicely demonstrated by the natural history of thyroiditis, which has many stages and transitions, with the first being the thyrotoxic stage, with low TSH and high thyroid hormone levels and low radioactive iodine uptake that can last from weeks to months. And this is followed by a transient euthyroid phase and then a hypothyroid phase that can again last for weeks to months before finally either normalizing, although about a third of cases with run-of-the-mill thyroiditis tend to actually end up having persistent hypothyroidism. It tends to actually end up being a much higher rate if it's due to an immune checkpoint inhibitor-induced thyroiditis. They tend to actually end up being permanent after the thyrotoxic state. The cause of the thyroiditis can be generally split into painless autoimmune etiologies associated with high anti-TPO titers and generally normal SED rates, or painful subacute thyroiditis, usually following a viral upper respiratory illness and characterized by elevated ESR rates and only mildly positive or negative anti-TPO antibodies. But a lot, like I mentioned earlier, more frequently we're seeing an increase because of the increased use of immune modulators and checkpoint inhibitors. We're seeing an increasing number of drug-induced thyroiditis, which can have features of both painful and painless thyroiditis. And here are some pathology slides comparing the normal thyroid tissue to a patient with granulomatous painful subacute thyroiditis. And you can see the multiple giant cells and the destruction of the thyroid follicles that normally contain the preformed thyroid hormone. And the treatment for the thyrotoxic stage of thyroiditis usually just involves beta blockers for symptomatic control. And NSAIDs or prednisone just for a few weeks to control the tenderness or inflammation, but not necessarily, we don't give thionamides because they're not helpful since the thyroid hormone is actually not being produced to suppress the TSH. And the elevated circulating thyroid hormone levels, rather than instead, it just reflect the leakage of the preformed thyroid hormones from this inflamed gland. The hypothyroid phase is typically mild and short-lived in papothyroiditis, and levothyroxine treatment is not often needed for granulomatous thyroiditis. However, hypothyroid phase in thyroiditis can induced by immune checkpoint inhibitors, like I mentioned in the previous slide. It tends to actually end up being a permanent, so we have a much lower threshold to start levothyroxine as soon as you have the transition from thyrotoxicosis to hypothyroidism, because those are in somebody who's received an immune checkpoint inhibitor. So another common situation that requires some understanding of the dynamic nature of the disease in order to interpret the thyroid function test is the sick thyroid syndrome. And this condition has many names, including the non-thyroidal illness, or the low T3 syndrome, or the iodinase 3 syndrome. So the latter two names actually fit pretty well, and they reveal a little bit of the underlying physiology. So as you may remember, T4 is converted to the more active T3 hormone by either the iodinase 1 or the iodinase 2, and they remove iodine molecule from the outer tyrosine ring of T4. In contrast, the iodinase 3 removes an iodine molecule from the inner tyrosine ring and converts T4 to an inactive compound called reverse T3, and also inactivates, so the iodinase 3 also inactivates the T3 by converting it to T2. So in non-thyroidal illness, the iodinase 3 activity is increased with a slight decrease in the iodinase 2 activity. And the net result is that in non-thyroidal illness, there's an increase in the reverse T3 and a decrease in the T3 levels. As the illness progresses, the liver makes less of the thyroxine binding globulin, or TBG, which lowers the total T4 levels without necessarily changing the available free T4. This is like the same concept that we talked about a little bit for cortisol. And here broken down the changes that occur in non-thyroidal illness according to the illness severity. In mild illness, this can occur with just a viral illness. There's a downregulation of D2 and an increase in the iodinase 3 expression, which results in increased reverse T3 and decreased T3 levels, but everything else stays the same. As the URI progresses to pneumonia, the process continues, but there's also a decrease in the thyroxine binding globulin, or TBG, which decreases the total T4 levels, but keeps TSH levels the same. And as the pneumonia progresses to ARDS and the patient enters the unit, there's a continuation of all of these processes, but with the development of a central hypothyroidism, possibly mediated through decreased leptin and increase in the cortisol levels. And finally, as the patient returns back to the floor from the ICU and they're starting to get better, the process begins to reverse with an increase in the TSH levels. And at this point, it can look like frank hypothyroidism. So an important point to keep in mind that in the recovery phase of a non-thyroidal illness, the TSH levels tend to be elevated with the low free T4 and low T3 levels. But one important distinction to make at this point is that the TSH levels, unlike other causes of hypothyroidism, the TSH levels in the recovery stage of non-thyroidal illness don't usually get above 25. So it also looks like this, the non-thyroidal illness process is an adopted process, as the T4 treatment repletion with levothyroxine has not been shown to benefit recovery in these patients. And this is what it looks like in graphical forms. And we can see is that the T3 levels tend to be low or suppressed throughout the entire cycle. And at no point is the active thyroid hormone levels elevated. So the TSH can be elevated, but that the T3 or the free T4 or T4 levels are always on the lower side. So because of increased imaging studies done in hospitalized patients, it's also worth reviewing some of the effects that iodinated contrast can have on the thyroid. So in most people, the clinical consequences of a large amount of iodine is a transient inhibition in the formation and release of thyroid hormone with a mild transient decrease in thyroid hormone production. And this is called the Wolff-Chaikoff effect. And there is typically a mild increase in the TSH just for a few days, and then the thyroid is able to escape the inhibition within about 7 to 10 days. However, iodinated contrast may precipitate a permanent hypothyroidism in patients who have susceptibility. And also, iodine can have the opposite effect in patients with autonomous thyroid adenomas and rarely in Graves' disease, in which iodine can precipitate hyperthyroidism by increasing thyroid hormone production. And this has been known to precipitate thyroid storm in hospitalized patients. And the treatment of this Jod-Basedow effect is methimazole. So in addition to contrast media, similar iodine-mediated effects can be seen in amiodarone, which contains about 75 milligrams of iodine, or about 7 milligrams of free iodine for every 200 milligram dose of amiodarone. In addition, amiodarone can result in iodine-independent thyroiditis, which can result in a transient hyperthyroidism. And the treatment for this type of amiodarone-induced hyperthyroidism, thyrotoxicosis, is prednisone. So you have either type 1, that's autonomous, that you treat with methimazole, or type 2, that's a thyroiditis that you treat with prednisone. And because of the very long half-life of amiodarone, there's no need to stop the treatment, because the iodine is going to be there for like at least another 2 months. So might as well still continue to get the benefits of the cardiac benefits of the drug. So to end the discussion, I'll just briefly talk about hyper and hypothyroidism, that these are common conditions that our patients will have. And I'll try to highlight specific features that may be of interest in the case of hospitalized patients. So this cartoon shows some of the signs and symptoms of hyperthyroidism, which are generally characterized by features of increased arousal and adrenergic tone. And I've highlighted some of those frequently found in hospitalized patients, including sweating, palpitations, anxiety, weight loss, tachycardia, atrial fibrillation, and hypertension. And some of the helpful signs for hyperthyroidism include the presence of goiter, tremors, warm, clammy skin, and hyperreflexia, along with some of the signs that are specific to Graves' disease that include the proptosis, pretibial myxedema, and thyroid bruit. And thyroid storm refers to the severe end of the spectrum of the clinical features in which patients develop delirium, hyperthermia, and cardiac and GI symptoms. And I'll talk a little bit more about that in the next slide. But an important subset of hyperthyroidism that we should all know about is apathetic hyperthyroidism, which typically occurs in elderly patients with hyperthyroidism who can present with lethargy and depressive symptoms and a paucity of adrenergic symptoms. And it should be considered in all patients who are admitted with failure to thrive. So it's not hypothyroidism, it's just basically apathetic hyperthyroidism. So they tend to end up having a suppressed TSH. So thyroid storm can result from any cause of hyperthyroidism in the setting of precipitants, such as like surgery, trauma, infection, iodine load, parturition, or withdrawal of antithyroid meds. And these triggers are common among hospitalized patients who may come in with hyperthyroidism. So it is worth knowing about a little bit about thyroid storm, as it has a very high mortality rate. The hallmark of thyroid storm is an altered mental status in the setting of more severe signs and symptoms of hyperthyroidism. And there are two widely used clinical criteria that have been devised and designed to distinguish thyroid storm from just compensated hyperthyroidism, and I've listed both of them here. The problem, to just know, it's worthwhile looking at them, but they're still relatively subjective, and while sensitive, they lack specificity. So I would say one of the most important things to end up paying attention to is going to be the presence of altered mental status, in which case you do actually end up biasing to actually end up assuming that the patient has thyroid storm as opposed to compensated hyperthyroidism. So TSH and ACG in pregnancy can both activate the TSH receptor in the thyrocytes on the physiological condition. But it turns out in Graves, which is the most common cause of hyperthyroidism, accounting for about 70 to 80% of cases, the activation of the TSH receptor is caused by these activating autoantibodies, as illustrated in this cartoon. The other 30% of causes of hyperthyroidism include autonomous nodules, thyroiditis, exogenous thyroid hormone administration, or rare causes that I've also listed here. And to determine the cause of thyroid toxicosis, we can either measure the TSH receptor antibodies, which include the TBII or TSI, or thyrotropin binding inhibitory immunoglobulins, that's TBII, or the thyroid stimulating immunoglobulin, which is the TSI. And these have greater than 95% sensitivity and specificity to rule out Graves' disease in frank hyperthyroidism. Or we can do a radioactive iodine or technetium uptake and scan test. As I mentioned, that the etiology of hyperthyroidism can be done by measuring these uptake and distribution of either radioactive iodine or technetium in the thyroid. And we divide the causes of hyperthyroidism to those associated with increased uptake and those with decreased uptake. Low uptake hyperthyroidism is caused by thyroiditis, in which preformed thyroid hormone is just dumped into the circulation by the inflamed gland, like we talked about before. You can have the exogenous thyroid hormone intake, which suppresses gland function and is associated with low thyroid globulin levels, or iodine-induced hyperthyroidism, or recent iodine load, which interferes with the radiotracer uptake. But more commonly, in the absence of prior iodine exposure, the cause of hyperthyroidism is associated with increased iodine uptake despite the suppressed TSH due to either Graves or autonomous nodules. The pattern of uptake helps us distinguish Graves, which has a homogeneous uptake, from autonomous nodules, which can be either single or multiple and gives you a very heterogeneous distribution of the tracer material. And here I'm showing a real example of a patient who had increased homogeneous uptake of about 40%, which confirmed the diagnosis of Graves' disease, even though the antibody titers were negative. So treatment of hyperthyroidism should focus on both the immediate control of symptoms and reversing the cause of excess hormone. And beta blockers are used for the treatment of almost any type of hyperthyroidism, including thyrotoxicosis from thyroiditis, as many of the symptoms of hyperthyroidism are caused by upregulation of beta-adrenergic receptor signaling. So for standard hyperthyroidism, any beta blockers will do, and it's not just limited to propranolol. In fact, we tend to prefer the longer-acting beta-1 selective beta blockers like atenolol and metoprolol as the initial treatment for symptom controls. For autonomous thyroid function, thyronamides like methimazole or PTU, or propylthiouracil, can be used as both temporizing measures to decrease thyroid hormone levels or to induce long-term remission in Graves' disease, with success rates varying between 25 and 75%, depending on the disease severity and the size of the goiter. Other definitive treatments of hyperthyroidism include therapeutic radioiodine ablation or surgery, and a lot of what you choose will depend on the contact. The two commonly available thyronamides, methimazole or PTU, both work by inhibiting production of new thyroid hormone, and that's why they're not used to treat thyroiditis, which is the release of preformed thyroid hormone. And methimazole is more potent and has a longer half-life, so it can be dosed once a day, with typical initiating starting dose being about 15 to 30 milligrams, depending on the severity, with a maintenance dose of about 5 to 10 milligrams per day. In contrast, the typical dose ranges from 50 BID to 200 TID for PTU. Both agents are associated with rash, agranulocytosis, and ANCA-positive vasculitis, although the risk is much greater with PTU compared to methimazole. Both have liver toxicity, but this tends to be more severe with PTU. And because of its effect in decreasing the T4 to T3 conversion, PTU may be preferred in the treatment of thyroid storm, although this is now being challenged. So more and more people are just sticking with methimazole. But just know that traditionally that has actually been the case. And PTU is also recommended over methimazole in the first trimester of pregnancy due to teratogenic potentials. So treatment of thyroid storm consists of, first, controlling signs and symptoms of increased adrenergic tone with a beta blocker. Propranolol is the preferred agent because it has been shown to block T4 and T3 conversion in a thyroid storm. Relatively higher doses are needed, between like 60 to 80 milligrams every 4 to 6 hours initially, due to the increased metabolism of the drug in the setting of hypothyroidism. Next, high doses of either PTU, about 200 milligrams every 4 hours, or methimazole, 20 milligrams every 4 to 6 hours, are added to decrease the T4 synthesis, with PTU having the additional benefit, like I talked about, of decreasing the T4 to T3 activation. And then iodine in the form of either saturated solution of potassium iodine, about 5 drops every 6 hours, or Lugol solution, about 10 drops every 8 hours, is given at least 1 hour after thionamide administration. Really important that it's after you end up blocking the formation, because you don't want to have you don't want to actually end up having a Jod-Basedow effect of potentiating the production of thyroid hormone. And the iodine in this setting is going to be to try to actually end up inducing more of the Wolff-Chekhov effect and blocking the release of thyroid hormone from the gland. Stress dose steroids, as either hydrocortisone 50 to 100 milligrams every 8 hours, or dexamethasone 1 to 2 milligrams every 12 hours, are given to decrease the T4 to T3 conversion and for the treatment of any possible underlying adrenal insufficiency. And bile sequestrants like cholestyramine can be added to decrease the enterohepatic recycling of thyroid hormone. And acetaminophen is preferred over aspirin for the treatment of fevers, as aspirin can displace the bound thyroid hormone and transiently increase, make the symptoms a little bit worse by increasing the circulating thyroid hormone levels. And finally, just a few words about hypothyroidism. This cartoon shows some of the signs and symptoms of hypothyroidism, which should be in the differential for patients admitted with failure to thrive and myalgias, and sometimes associated with mild elevations in CPK. Some common signs include the dull blank expression, periorbital puffiness, thinning of the outer third of the eyebrows, as can be seen with chronic hypothyroidism. There's hoarseness and a thick tongue that can result in obstructive sleep apnea. There's a delayed relaxation phase of the deep tendon reflexes. So the action the reflexes are normal, but then the relaxation phase is quite delayed. They can have non-pitting edema, bradycardia, diastolic hypertension, or pleural pericardial effusions. Some associated labs of hypothyroidism include hyponatremia, hypocholesterolemia, anemia, and sometimes primary hypothyroidism can also result in increased prolactin elevation. In severe cases, hypothyroidism, as hypothyroidism progresses to mixed edema coma, this can be characterized by delirium, hypothermia, hypotension, bradycardia, and hypercapnia from decreased respiratory rate. And these patients will typically need treatment with IV thyroid hormone. So most causes of hypothyroidism are primary and have a characteristically elevated TSH levels. Less than 5% of hypothyroidism has a central etiology and is characterized by low or inappropriately low TSH levels. So you do need to check the free T4 levels. And these are usually caused by hypothalamic or pituitary disorders, but also by glucocorticoids, which tend to decrease the TSH levels. And remember to check if the patient recently received systemic steroids, if you ever see a suppressed TSH, that may, if you're actually considering like a central hypothyroidism, because the steroids may actually end up being the cause for the suppressed TSH. But by far, the most common cause of primary hypothyroidism is autoimmune destruction of the thyroid gland, and that accounts for about 90% of cases of hypothyroidism, and most of these also have elevated anti-TPO antibodies. However, as we discussed earlier, immune checkpoint inhibitors frequently cause permanent hypothyroidism, and the anti-TPO antibody titers tend to remain negative. So worldwide, iodine deficiency is a common cause of hypothyroidism, but we don't see this too frequently because we add iodine to the salt in the US. And then thyroid dysfunction due to surgery, radiation, or drugs are also important causes of hypothyroidism that you should at least know about. And the treatment of hyperthyroidism is relatively straightforward, consistent of levothyroxine. There are many formulations that are available, and they're all generally equivalent. The typical treatment dose is approximately 1 microgram per kilo, or about 0.6 micrograms per pound. However, if the TSH is less than 10, you can start with a lower dose of about 1 microgram per kilo per day. It's also important to remember that in the elderly, you should start low and go slow, as thyroid hormone increases the oxygen demand of the heart. Patients should take thyroid hormone fasting and ideally wait at least 1 hour before eating to optimize the absorption. And because levothyroxine has a long half of about 1 week, if a patient skips a dose, it's okay to have them double up the following day. It's the weekly dose that really matters. And then given the long half-life, we need to recheck TSH in about 5 to 6 weeks to let the levels equilibrate before adjusting the dose. And in terms of follow-up, we typically only need to follow the TSH and add free T4 measurements only if this is abnormal. And in general, T3 measurements are not recommended except for rare cases. And there are many things that can alter thyroid hormone levels. The most common one in the outpatient setting is variable compliance. But keep in mind, sometimes levothyroxine gets mistakenly dropped from the home meds in some hospitalized patients. Other factors that involve either intake or absorption include variable eating schedules or 2 feeds, vomiting, the use of antacids or PPI, bile acid sequestrants, or vitamins containing positively charged elements that interfere with the absorption. In addition, any condition resulting in malabsorption may require increase in the levothyroxine dosing. Also need to keep in mind that conditions that affect protein bindings that I've listed here also affect the dose, with higher doses needed in the setting of increased TBG, thyroxine binding globulin, and the opposite being the case in the setting of decreased TBG, as can occur in non-thyroidal illness. Finally, there are many drugs that increase the clearance of thyroid hormone and may require increased dosing. Sometimes amiodarone does this by blocking the conversion of T4 to T3, and the T4 levels, the free T4 levels tend to be a little bit higher, and you may need to end up increasing the dose of levothyroxine. So hopefully that's all I have. Hopefully you find this useful. And I would just like to thank again the organizers for inviting me to present to you today.